Okay, good morning. So as Dr. Lippman mentioned earlier in the introduction, the clinical application, the rationale behind it for prostate, high-dose rate prostate brachytherapy stems from both its technical capabilities of the HDR brachytherapy and also some of the radiobiological properties of prostate cancer. So in the next 10 minutes, we're going to discuss the radiobiological aspects of HDR brachytherapy for prostate cancer. So I hope by the end of this talk, we will know a little bit more about the relevant radiobiological models to use and hopefully know the key radiobiological features of HDR brachytherapy, and then understand why prostate cancer is considered to be suitable for hypofractionated treatment. And also, hopefully we know some of the issues potentially that can affect the treatment effectiveness that we need to consider as we move towards extreme hypofractionated treatment for prostate cancer. So the HDR prostate brachytherapy are typically delivered in multiple fractions. And at the time separating the two fractions are usually longer, at least 6 hours or more. The dose rate during the delivery of each fraction can be considered constant. So in that sense, the temporal pattern of this modality is very similar to the fractionated treatment used in external beam radiotherapy. However, the dose distribution within the target volume is much more heterogeneous. As we mentioned earlier in the last couple of days, both the temporal pattern and the spatial distribution can have an impact on the treatment effectiveness, and both has to be considered from the radiobiological point of view. As discussed in Sunday, and cell survival has been used as a convenient surrogate for the biological effect of radiation. And linear quadratic model is one of those models that have been used in clinical studies. And this particular model, you can incorporate cell proliferation and DNA damage repair, the effect of dose protraction in a sort of simple formalism. So for HDR brachytherapy, the time separation between the fractions, if it's 6 hours or more, and the repair half-time for prostate from the TG131 endorsed consensus data set is about 16 minutes. So we have this sort of condition established that the time between the fractions are much larger than the repair half-time. So you can consider damage repair is complete between the fractions. We don't have to consider those effects into this dose protraction factor. In this case, it becomes a simple dose protraction factor for each fraction divided by the number of the fractions that you use. And as for the constant dose rate irradiation, this dose protraction factor for each fraction becomes relatively simple. And as we talked about before, if the dose is delivered instantaneously and this protraction factor becomes 1, there's no impact. However, any elongation of the treatment duration, it will always reduce this dose protraction factor, leading to a less effective treatment. So just to remind you, now the corresponding BED and EQD2 formalism for HDR brachytherapy is going to be looking like this. Theoretically, should put that one here. And with these two, we can use it to compare the relative effectiveness of different treatment fractionation schedules, and also try to use it for deriving iso-effective treatments. And typically, these are the models that are used. And in fact, most of the report for HDR brachytherapy in the literature are based on these simplified equations, which is good if the dose delivery time for each fraction is short. And as we will discuss, it may not be adequate as we're moving toward extremely hyperfractionated dose delivery. So these models are useful to try to illustrate the basic features. And here is, we're going to run through this very quickly. And the BED is reflective of the biological effect. So it's very easy to see once you have this kind of formalism, the increase in dose, total dose, you will increase the biological effect. That's kind of obvious. And also, if you're given the same dose, if you increase the fraction size, it will also increase the biological effect. And this increase is dependent on the tissue property. If the alpha beta ratio for the tissue is small compared to another one, the same dose fractionation scheme will yield different biological effect. And obviously, any presence of intrafractional repair is going to reduce the effect of the treatment. Similarly, the presence of cell proliferation. So now we know everything about the radiobiological features of HDR brachytherapy. Now this, I put it here, I know everybody probably already know the rationale for why prostate cancer is considered suitable for hyperfractionation. And because this is a summer school, and for those people who wanted to get a little bit more, so I'm going to step through this, and I think after that you will have a more clear picture why it is. Now, we talked about before, the BED depends on the fraction size for given total dose, and also depends on alpha beta ratio. And this inverse of alpha beta ratio basically serves as a coefficient for the fraction size. So if we increase the fraction size and the tissues with a smaller alpha beta ratio, you'll see a more effective. Tissues with a smaller alpha beta ratios is going to be more sensitive when you change your fraction size. And in a normal situation, because the tumor are always surrounded by normal structures or critical organs, so when the tumor has a relatively larger alpha beta ratio compared to the surrounding normal tissue, say 3, when you increase the fraction size, you will have more biological effect on the normal tissue, which has a smaller alpha beta ratio. So in order to keep the normal tissue complication the same, you have to reduce the dose, and leading to a loss of therapeutic ratio. Prostate is probably one of the very few tumors that actually have a alpha beta ratio potentially lower than the surrounding normal tissue. Since the publication of this seminal paper by Brenner and Hall, there are lots of papers published and debated about what the alpha beta ratio for prostate cancer should be. And I think currently the general consensus is it's going to be low, somewhere between 1.5 to 3. The AAPM endorsed consensus data set uses 3. Now, but you can see if the alpha beta ratio for prostate cancer is small than the surrounding normal structure, then there is this potential here. And this is a plot of the ratio of the relative effectiveness of the tumor relative to a normal tissue with the alpha beta ratio assumed to be 3. So in the case of a typical tumor, then you have a loss of therapeutic ratio as you increase the dose rate of the dose delivery. On the other hand, for a tumor with this small alpha beta ratio, and you have a increase in the therapeutic ratio. So the fact that the alpha beta ratio for prostate may be low or may be lower than the surrounding normal tissue, it is one of the main rationale driving the current move towards hyperfractionation or extreme hyperfractionation in HDR brachytherapy. So now we have these pictures. Now it's good we just go to extreme hyperfractionation, and which should be good because it reduces the logistic burden that typically associated with HDR brachytherapy because you don't need to do multiple implants. So what are the potential issues? So the model is also helpful, try to delineate the potential issues. For one, all these alpha beta ratios that are currently reported are based on clinical studies of the outcome treated from external beam or LDR permanent implant or the combination of external beam with HDR. So they are based on a population averaged outcome data. So the numbers that are put out there, authors often quote a large uncertainty. The uncertainties itself from this kind of study can range from anywhere from, say, alpha-beta ratio of a little bit over 1 to 5. Now, if you can imagine for individual patients, and if there's a potential that the alpha-beta ratio for certain patients can be much larger. Now, in that situation, if your treatment scheme was derived based on a alpha-beta ratio of 1.5, application on those patients can be bad. And the worst thing is that those situations are not readily be able to pick up because we don't have currently a way to do a bioassay of alpha-beta ratio for individual patients. Then you may contribute the worst outcome to a different confounding factors. Now, other issues is that for HDR treatment, if we are moving towards hyperfractionation or extreme hyperfractionation, the dose delivery time will increase. In the traditional 6 gray scenario, each fraction is delivered about 7 minutes and with a 10 curie source. When you move to 19 gray monotherapy, which has been reported in the literature, then the treatment time increases to 22 minutes. Now, irradiance source decays, and typically in US, we do source change on a quarterly basis. So by the time it reaches 19 days, the time needed to deliver this fraction is going to be 16 minutes, and then close to an hour when you deliver a single fraction treatment. And if we recall the data from the AAPM endorsed parameter set, the repair half-time is about 16 minutes. So now both of these are larger, close or significantly larger in the single fraction cases. And this can have a tremendous impact on, or at least a theoretical impact on the treatment outcome. So my colleague, Christopher Ting, has done a study looking into this. Here is a nice picture. What plots here is the BED for alpha-beta ratio of 3 as a function of dose per fraction for different fractionation scheme. So here's an 8 fraction treatment up to 1 fraction treatment. The red dots that's showing here are actual clinical studies. And most of the clinical studies report the BEDs using the simplified model. And these are represented by here, this line. And if you take into account the intrafractional repair, and then the source decay, these are the BEDs at the fresh source and then at 90 days old. So if you look at this from here, as you decrease the number of fractions, going extreme hyperfractionation, then you can see the differences between calculate BED using the simplified model and the full model increases. And also the range increases also for the patients treated at a different time point within a source change cycle. So these differences can be 16% up to 30%. So there's a tremendous potential in terms of its implications on clinical treatment for individual patients here, and also on deriving consensus isoeffective treatment scheme in addition for the treatment outcome study, because all of these patients received different biologically effective dose, but they are lumped into a same dose in outcome study. There are other issues, for example, the existence of tumor hypoxia. Because of running out of time, I'm not going to dwell on that, but it's actually an interesting issue in the HDR case. They're not quite the same as compared to external beam delivery. And so in conclusion, the current models are useful in terms of trying to delineating or understanding the features of HDR brachytherapy. The model is known, have limitations, and especially say in this case, when we go into extreme hyperfractionated treatment, LDR, there's controversy about the LQ model applicability in the high dose range. And there are ways actually mitigating that, such as the linear quadratic linear model that proposed by Mariana here. I know she's very modest. She didn't want me to mention it, but that's a great work there. And also other factors that are not So these are sort of caveats, and obviously the clinical significance of this, what I was discussing earlier, when we try to move in towards the extreme hyperfractionation, it still need to be tested clinically. Thank you, and I was hoping that I can beat the buzzer, but apparently I failed again.